Good afternoon, everyone. I'm Nicole Cipriani, surgical pathologist at the University of Chicago. My subspecialty interests are in head and neck, bone and soft tissue pathology, as well as anatomic pathology informatics, and why we're all here, gross pathology. I would like to thank the AAPA for inviting me to lecture. I really love interacting with our pathologist assistants, colleagues, and I'm very much looking forward to chatting with you after this lecture. So let's begin with the hard and soft of it. We're going to be discussing grossing practices, techniques, and considerations for complex resection specimens of all types. I have no disclosures. To review our objectives, we will identify at least 4 methods to approach complex resection specimens involving both bone and soft tissue. We will determine when to use each of the discussed methods and understand how tissue should be processed differently when molecular testing may be needed. So we're going to do this lecture in terms of grossing challenges. Those grossing challenges are going to be closely associated bone, soft tissue, and tumor. Those are going to be tumor mostly in bone, not so much in soft tissue. Tumor mostly in soft tissue, not so much in the adjacent bone. We're going to be discussing scant soft tissue and very delicate bone. And then lastly, how you can interpret the need for molecular testing in all of these specimens. So to remind you, we do have a gross pathology website through the University of Chicago. All of our pages are freely available online. So if you do have an interest in reviewing our manual, please do so. Any feedback or comments are always welcome. We're always trying to make this a good resource for our prosectors. So before we get into the cases, I do want to review staging of sarcomas. And so this depends on the primary origin of the tumor being in the soft tissue or the bone, and then on the specific location. So for soft tissue tumors, these are subdivided by anatomic site. So of the head and neck, of the trunk and extremities, right, of the abdomen and thoracic visceral organs, of the retroperitoneum, and of the orbit. If you're dealing with a primary bone tumor, you're again subdivided by appendicular skeleton, trunk, skull, and facial bones all together. You then have the spine, you then have the pelvis. So remember, whenever you're dealing with a specimen of a soft tissue or bone tumor, please pull up that appropriate staging manual because as you can see, there's a lot of variation even within each of those stages. Prior to grossing each specimen, we should review certainly the biopsy diagnosis, any relevant radiographic findings, and then again, the relevant staging parameters in order to help determine the method of sectioning and to ensure that all appropriate staging items are documented. So the first challenge, we're going to push that ball up the hill, is closely associated bone, soft tissue, and tumor. I should say rock. I don't think it was a ball. I think it was a rock, right, Sisyphus? Okay. Anyway, such as this hand amputation in a 62-year-old female for recurrent synovial sarcoma. So we know our biopsy diagnosis is already a synovial sarcoma, which is generally considered a primary soft tissue sarcoma. The sarcoma, you can see, discolors the skin and probably underneath surrounds the small bones of the hand. It certainly erodes through the skin in this fungating mass on the thumb side. Unfortunately, in this particular case, radiology was not actually available. Clinically, this was considered a high stage, clinically recurrent sarcoma, essentially diffusely involving the hand. So we can assume some percolation between bone, perhaps some osseous involvement, depending on what we see when we open up the specimen. So this is a soft tissue sarcoma of the trunk and extremities in which staging is essentially only based on size. So in this case, of course, your sections are going to be critical, documenting the structures involved, but really for staging and for synoptics, we are concerned with size and as always with margins. For cases like this, ideally, they should be triaged or sort of opened up the same day as receipt because otherwise the tumor may not start fixing appropriately and may undergo additional degenerative changes. So I don't recommend just immersing this entire specimen in formalin and expecting the tissues to fix properly. We do want to sort of open it up to some state freshly. However, if it is very late in the day or you have no other recourse, these can be placed in the fridge to minimize degenerative change and then address sort of first thing the next morning. So what are the options for grossing this types of specimen? So the first option might be a technique that I'm going to call score. So this is where you score through the soft tissue and then cut through the bone with a saw. This can be done on fresh or fixed tissue. It preserves the relationships of the bony to the soft structures. But the cons are it may sort of result in uneven sections depending on how much interface there is between bone and soft tissue, the skill of the grosser, the complexity of the specimen. This might be something to consider, however, when most of the pathology is in the soft tissue and there is just a single, simple sort of core of bone. Not exactly what we have in this case. Then there's what I'm going to call shave. So shave is when you shave off as much soft tissue as you can, and then you gross the soft tissue and bone separately. This again can be done in the fresh or fixed state. It unfortunately, though, does not preserve much relationship between the soft tissues and the bony structures and can be done when most pathology is in the bone, such as in an osteosarcoma with minimal soft tissue involvement. Again, not really what we have in this case. We expect very complex bony anatomy, and we expect at least a lot of soft tissue and possibly some bone involvement. Then there's freeze. This is where you freeze the fresh specimen in either liquid nitrogen until it's hard or in a deep freezer, such as overnight, and then cut the entire thing with a large saw. This does preserve the relationships of the bony and the soft structures, usually does result in nice even sections because you've homogenized the consistency of the entire specimen. Cons, this can really only be done fresh, so it is time sensitive. You cannot do this post-formalin fixation. Some people ask whether the freezing distorts the morphology. I would argue that it's not a huge distortion, but it's certainly something to consider in cases like this. But we've had success with this method without too much distortion of the H&E slides following. When to consider this is when soft and hard parts and tumor are very intimately associated, such as soft tissue tumors surrounding and or invading bone, or bony tumor invading soft tissue. So maybe we're getting close to what we might do in this case. And lastly, there's the fix and decal technique, which I always use as a last resort, really. This is where the specimen is fixed entirely in formalin, decalcified entirely, and then cut just with a long blade. So this case obviates the need for a bone saw. You can use a long blade. It does preserve the relationship of the bony and the soft structures. Again, usually results in pretty clean, even sections, but does require decalcification of the entire specimen and may eliminate the possibility of molecular testing on the tumor because of the decalcification process. I would consider this when the bone is very sparse or thin and delicate and might suffer extreme fragmentation from using any of the above techniques and a harsh bone saw. So this might be something like a maxilla or a mandibular alveolar ridge. So back to our case, remember, the sarcoma is expected to surround the small hand bones. You can see it diffusely involving the skin, at least superficially. So we assume it's also involving those deeper compartments. So in this case, we're going to go with that freeze technique. We're going to freeze it in either liquid nitrogen or deep freezer overnight. We will be able to cut it with a large bone saw, preserving those anatomic relationships. But again, this has to be done in the fresh state. So we will freeze this specimen entirely. Remember, the only true margin on this specimen is that soft tissue surrounding the radius and ulna and the cut bony margins of the radius and ulna. So this area should be inked, but otherwise we can go forward with the sectioning. Oops, excuse me. So what we're going to do is, once frozen, the specimen will be sectioned perpendicularly across the whole hand into slices. The thickness of your slices once frozen might depend on your saw, as well as your agility and your comfort with the saw. I have no problem with these sections being a little bit thicker up front. We can always thin pieces of it down later, but it's most important to get the sections while fresh so that we can start the fixation process. At the University of Chicago, we have an exact diamond saw. This can cut through fresh tissue, fixed tissue, certainly through frozen tissue. In fact, it can actually cut pretty successfully both through hard and soft tissue. But in the case of this hand, where there are multiple tissue planes, sometimes there is sort of slippage or dragging of the tissue if there is a combination of hard and soft. Therefore, by freezing the specimen, you've turned the soft into hard, and you were able to get very clean cuts through the whole thing. So here's serial sections of that hand after it has been frozen. We see the margin slice on the right with the inked soft tissue and the cut radius and ulna margins. We see bones with some hemorrhagic and or pale areas surrounding the bones. As we walk up the hand, we can again see the sort of fleshy tumor with a very close association of hard and soft tissues. And after the specimen has thawed, we've taken these photographs. And so it essentially, again, sort of looks fresh colors, right? Fresh, bright yellow, fresh, bright red, because this has never been placed in formalin yet. We can see here as we walk up the hand into the area of the metacarpals that we are able to maintain that relationship between the metacarpals, between the intervening soft tissue, between these fleshy lobules of tumor. So again, our metacarpal bones are highlighted with the red arrows, the tumor with the blue, and we very nicely preserve those relationships for gross evaluation. These slices ended up being about 1 centimeter in thickness, which is of course too thick for submitting in cassettes. So what are our options for submitting after formalin fixation, of course? So what we do is we tend to fix these slabs or these slices in formalin overnight. We can then more delicately dig into the areas we need, do additional cutting with a smaller saw if we need to. What I would recommend is we isolate areas of soft tissue without bone that are soft and do not need decalcification, thin these areas down with a knife and submit these in our regularly sized cassettes. We can also isolate areas of tumor and the interface with bone. Again, sort of decalcify only those sections of tumor interface with bone, and then we can thin them down with a regular knife blade after that segment has been decalcified, okay? So I don't recommend that you throw the entire slab in decal, because it's probably gonna take a long time, and again, may sacrifice tumor for possible molecular testing. We've also used this exact same freezing technique for primary bone tumors with extensive soft tissue involvement, as in this hemipelvectomy for osteosarcoma. Again, you can see the tissue is very red, so in fact, it has been cut fresh. And you can see the tumor invading originating in the bone, I should say, but with an expanse out into the soft tissue, surrounded by more soft and or fibrotic kind of musculature. So freezing the specimen in this case allowed us to get a very nice section through all of the relevant anatomic compartments. We've also used this in a very similar specimen to the hand, but actually a lower limb amputation for osteosarcoma, in which again, we have a soft tissue margin that would be inked, and then serial sections through the specimen. Here showing a primary osteosarcoma of bone, but with extensive soft tissue involvement, such that the bone that would have been in the core of this is actually gone. So remember that again, just like the lower, the forearm, the lower limb has 2 bones, right? The tibia and the fibula. What do we really see here? We only see 1. So we can assume that the second bone has been essentially diffusely effaced by tumor. So our second challenge is going to be tumor mostly in the bone, such as this arm amputation, unfortunately in a young patient, a 4-year-old male, for a humeral osteosarcoma. So we have our biopsy diagnosis of osteosarcoma, primary bone sarcoma. We have the location being in the humerus. So let's check the radiology. In this case, we have excellent radiographic images, specifically this MRI. So the red dots highlight the extent of the tumor in the humerus. The radiographic report reads that the proximal humerus has been expanded, measures, 4.4, et cetera, centimeters, with extensive bone marrow signal abnormality. And I think you can appreciate that on this MRI. The only normal parts of the humerus are the proximal epiphysis and then the very distal epiphysis seen down here. There was no significant soft tissue involvement. So all of these are critical for our evaluation of the case. You can see on these other two images, involvement of the humerus here with preservation essentially of the humeral head, and then involvement here mostly of the proximal, but also extending into the distal. Okay, so this is a primary bone sarcoma of the appendicular skeleton. So for our staging parameters, this is based on size as well as discontinuity or multiple foci within the same bone. So just based on radiology, we can assume that this is probably a solitary but large lesion. And we would also want to know if there are skip lesions in the other bones of the arm, such as the radius and ulna. In this case, there were no radiographic skip lesions, but that would certainly be something that you would want to look for radiographically to know how extensively to section and or sample the forearm. So in this case, we're going to use the shave technique where we will shave off as much soft tissue as we can and sort of gross the soft tissue in the bone separately, because most of the pathology is in the bone, not too much we're going to see in the soft tissue. This can be done in the fresh or fixed state. It may not preserve very well that relationship between the bone and soft tissue, but again, if there's not much tumor in the soft tissue, then we're probably okay. So in this case, the soft tissue was removed, shaved, and the inner humeral bone was essentially kind of cored out. This is good, as I said, when most pathology is in the bone. When you don't have a saw that can cut hard and soft tissue together, like we've seen in the other amputations, when you don't want to freeze the specimen, or when your specimen is fixed and cannot be frozen. So there are various reasons why you may want to use this technique as opposed to the freezing technique. Here again, the bone was isolated and then cut longitudinally with a bone saw. So here we've excavated the bone, for lack of a better word, and we've bisected it longitudinally to open up the tumor. You can see that there is in fact a fracture kind of in the middle of the humeral shaft, but there's diffuse abnormality throughout, most prominently in the more proximal portion, which was reflecting what we saw in the radiology. We've also used this technique for primary bone tumors with minimal attached skin. I know we showed you a drastic example of an arm amputation, but you can also use this when there's very little skin, as in this case, where there's just skin with a biopsy tract in this distal femur, again for osteosarcoma. Here's seen from the anterior and posterior views. So what we would do is essentially amputate where that red dotted line is, removing the skin in the biopsy tract, because we've looked at our radiology, we've shown that the tumor is essentially all on the bone. The only reason that that soft tissue is there is because they always resect the biopsy tract along with the sarcoma. That's for reasons of possible seeding of the biopsy tract from tumor as it's pulled out. So you should always generally expect to see an ellipse of skin with that underlying tract excised. It should always be sampled in the event that there may be tumor in there and sectioned, but the bulk of our interest is going to be in that bone, right? So then we can take that smaller fragment of bone and section it with our bone saw. For these types of cases, I usually do one sort of mid-coronal full face section and then perpendicular sections on opposite side. If it's a larger bone, you can do multiple mid-coronal or multiple coronal sections, but then always remember to sort of perpendicularly section on either side of that. Why? Osteosarcomas are can be very heterogeneous. Here's what it looks like on the mid-coronal section, and again, those perpendicular sections. And so we see the bulk of the tumor here, pushing out the periosteum in the so-called characteristic Codman's triangle. And then we see it involving already, additionally, the perpendicular anterior and the perpendicular posterior cuts. We do in most cases want to block in that full cross section with a cassette map as seen here again in the post-fixed state. Osteosarcomas are usually resected only after chemotherapy in most cases. The percent treatment response is crucial in these cases and determines the need for adjuvant therapy. So 90% necrosis or 90% treatment effect is the cutoff. So greater than 90% treatment effect or necrosis, no additional therapy. Less than 90%, additional therapy. So this is the reason we would like really extensive sampling and full sectioning of those bones, because as I said, the tumor can be only focally viable, can be very heterogeneous. You want to look for fleshy areas as potential viable tumor. So don't just make one cross section and leave the rest go. Again, always fully evaluate all components of that bone. So here's a second example of this humerus that is now going to be blocked in this map from top to bottom. We will also representatively sample those perpendicular cuts from the anterior and posterior sides, as in the case of that femur. Yes? Okay. The next challenge is tumor that is mostly present in the soft tissue, such as in this segmental mandibulectomy for squamous cell carcinoma. So we have the histologic diagnosis. The carcinoma is predominantly in the mucosa and soft tissue, as determined by visualization, palpation, and of course, radiology. But we do notice that we have a little bit of maxilla up at the top, and certainly a core of mandible at the bottom. So we can see maxillary molars up here, presumably with some maxillary bone above it, and then a mandibular molar with a large core of mandible bone. To remember the types of mandibulectomies, we are either dealing with segmental or marginal. Segmental being essentially an entire full segment of the mandible, where you have two cut bony margins, the anterior seen here in red and the posterior in green. This is a segmental mandibulectomy, which we see in our case above. A marginal is different. It literally only takes the upper margin or the upper border of the mandible with the teeth. So you have the anterior cut, you have the posterior cut, and then you also have that inferior cut where you sectioned through the mandibular bone and sometimes even through the teeth. This is a marginal mandibulectomy, which is sometimes also called an alveolar ridge resection, right? The alveoli are your tooth sockets, so this resects the tooth sockets. Okay, back to the radiology in our case. It shows on MRI an infiltrative mass involving the right buccal or cheek mucosa, the posterior mandibular alveolus, the retromolar trigone right behind the molars, measures about 45 millimeters, right? So 4.5 centimeters. There also appears to be some erosion of the mandibular ramus here with underlying abnormal bone marrow signal. So we can expect some potential bony involvement, but most of this is a gingival or buccal squamous cell carcinoma with mostly soft tissue involvement. So this is a head and neck carcinoma of the primary site of the lip and oral cavity. So buccal, mucosa, gingival, retromolar, trigone, all being oral cavity, right? So in this case, stage is based on size, depth of invasion, or called DOI, as well as involvement of bone. So what sectioning are we going to use in this case? We're going to score. So we're going to score through the soft tissue and then cut the bone with a bone saw. Pros, to remind you, are this can be done on fresh or fixed tissue. This preserves the relationships between the bony and soft tissue structures. But sometimes if your cuts between your blade and then your saw are a little out of line, you may get a little bit of uneven sectioning. However, just be mindful of where your scored edges are and try to continue those cuts on the bone saw in as clear of a manner as you can. Again, most of the pathology in this case is in the soft tissue with essentially a core of mandibular bone. For these types of specimens, we have a tabletop IMEB diamond saw. This can really only cut through hard tissue. So if you're expecting to cut through any of those soft, it will just shred it. Good thing is you can cut both fresh bone and fixed bone, but size limitations. You can see this is sort of small. So you're really only dealing with smaller pieces of tissue like mandible, like maxilla, like smaller sections of bone, in which using the larger bone saw might actually do more harm than good. So in this case, we use the smaller tabletop. So in this case, you can see it's fixed. It's been inked. Sorry about all of the colors inking. But you can see that there's a little bit of a central core of red, but most of the tissue is turned sort of brown. So this is post-fixation. So here we've scored the soft tissue with a blade and then cut the bone with a saw. So here you can see the areas in red that were just done with a regular long blade knife and then continued with the bone saw in the same plane, or the areas highlighted in green. Remember, both bone and native teeth, mostly composed of dentin with a little bit of enamel, will cut with a bone saw and will decalcify at similar rates as bone. So I consider bone and native teeth to be essentially one and the same. These slices, again, were a little bit thicker than usual, maybe 1 centimeter. So again, after fixation, we can certainly isolate those areas of soft tumor without bone, thin them down with a knife, don't decalcify them, perfect. Then you might also want to isolate areas of bone tumor interface because we need to determine for staging, right, if tumor involves the bone. So we certainly want to sample the bone in areas where there is overlying tumor. And then we will cut those, isolate those down, perhaps decalcify those smaller segments, and then thin them down with a regular knife after decal. All right, next challenge. Scant soft tissue and very delicate bone, such as this alveolar ridge resection or marginal mandibulectomy, right, for squamous cell carcinoma. So we have our biopsy diagnosis of squamous cell carcinoma. This concept can be applied to both maxillary and mandibular alveolar ridge resections, which tend to be more delicate specimens. You can see here there's 3 teeth. You can see that the carcinoma, or at least the ulceration, right, is in that very thin mucosa covering delicate bone. And we may destroy the lesion by trying to shave off the gingiva, by trying to freeze it all and use a bone saw. So in this case, let's evaluate the undersurface. We see that this is not a segmental mandibulectomy, right? This is a marginal. So we can expect the anterior, posterior, and in this case, inferior, right? That inferior margin is looking right up at us. We see both a transected marrow and cut portions of teeth. So we have a cortex on one side, a cortex on the other, and teeth. We see that the tissue covering the bone tends to be somewhat scantier and delicate. We see that the bone has been transected such that the marrow space is now open, right? And we have the roots of teeth that have also been cut. So in this case, this is the rare case in which we may actually want to use the fully fixed and fully decalcified technique so that you don't have to use a bone saw at all. You will preserve those relationships of the very delicate gingiva and very delicate tumor to the bone, right? Because you want to know if it invades the bone, because that is important for staging. But in this case, we will fully fix and then fully decalcify the entire specimen. But again, if you are in the need for molecular testing, you may not want to do this in an HCl decalcifier because you will no longer have the need for you will no longer be able to do molecular testing. We'll talk about molecular later. Don't worry. Just keep this always in the back of your mind. So again, we're going to use this when the bone is sparse or thin or delicate and would suffer fragmentation otherwise. So if you want to decalcify your whole specimen after formalin fixation, of course, please discuss with the pathologist first. Just determine if there is a prior non-decalcified biopsy, which may determine your ability to use either harsh HCl or a gentle decalcifier. Again, we will discuss this, don't worry. But consider all options first before deciding on this sort of last ditch approach, because it will require, as I said, decalcification of the entire thing. But there are benefits to it. In this case, as I said, the teeth and the bone fixed similarly, decalcify at similar rates, cut very similarly. But the fillings, The cement, any metal hardware will not fix or decalcify or cut, right? So these need to be removed from the choppers. So you can see in this case that there's a nice metal filling surrounded by normal tooth. So in this case, the tooth's not a problem, but it's the filling that's the problem. Sometimes after decalcification, the tooth and or bone kind of thin out a bit so that sometimes these fillings can be sort of popped out. If you have like plates or hardware, you certainly would want to sort of unscrew those and remove them. If you have crowns and caps, again, you can sometimes pop those off, especially after the tooth has kind of thinned down after decalcification. But each specimen is different and of course should require a different evaluation depending on each different specimen. So in this case, the entire thing was fixed, the entire thing was decaled, and it was cut with just a long blade, not a bone saw, just a long blade. But you can see we were able to cut through the cortical bone and the tooth and of course the soft tissue tumor. So we now have a beautiful tumor interface to tooth, to bone. These sections can be submitted, they're cut thinly and can be submitted as is, right? Because they're already fixed, they're already decalcified, you've already got your margin ink on there, done. One thing that we could do if there's redundant tip of tooth, as you can see here, you can cut the sort of little tip of the tooth off. You probably want to preserve whatever root of the tooth is in the bone because that will be important for any interaction between tooth and bone and tumor. But the little tips that are floating around in the mouth that don't have any tumor nearby, those can be gotten rid of if that makes sense. Okay, so we've discussed the freezing technique, the shaving technique, the scoring technique, and the fix and decal techniques. However, in any of these specimens where decalcification is necessary, we always have a challenge of potential molecular testing. This is, of course, not a problem with soft tissues or soft tissue tumors, but it does become a potential problem with any bony or any calcified tissue in which molecular testing is needed. That's either for a neoplasm, right, to detect a mutation, a fusion, etc. Sometimes even for infectious cases, for non-neoplastic cases, to detect organisms, like in cardiac valves, in calcified synovium, or in osteomyelitis. Sometimes molecular testing is used for organisms if they cannot be cultured or otherwise identified. This is less utilized, so we're not going to focus on it, but always remember this. And sometimes don't be surprised if molecular testing is requested for infectious diseases. It can definitely identify those organisms. Okay, we're going to mostly focus on the neoplasms. So we need decalcifiers that preserve the nucleic acids, whether it be for NGS, next generation sequencing of DNA, whether it be, or RNA for that matter, whether it be a polymerase chain reaction of DNA PCR, or whether it be tissue fish, fluorescence in situ hybridization. All of these techniques require preservation of nucleic acids. On the other hand, immunohistochemistry, right, which detects proteins in tissue, is sometimes affected by decalcification, but proteins are generally more resistant and immunostains usually work okay on decalcified tissues. So less of an issue with immunostains, but definitely an issue for anything that requires nucleic acids. Sequencing, PCR, fish. All right. So decal can certainly be performed, as you know, for bone, teeth, any calcified tissues or tumors or lesions that of course you cannot cut with your knife and therefore cannot cut with a microtome in histology. As you know, full fixation is always performed before decalcification in all circumstances. As I said before, never decalcify an entire specimen without consulting with a pathologist first. You want to check to see if there is pre-existing non-decalcified biopsy. If there is not, you will want to decide on your extent of decalcification using either harsh HCl or gentler EDTA. All right, so we're going to get to what that means. Always try to isolate any soft lesional tissue, right, to submit without decalcification, whether that's, as we saw in the prior examples, tumor next to bone, soft tumor, even that is encased within bone, or any kind of tumor area that is non-calcified, right? So if you can isolate any soft tumor, let me say, without need for decalcification, use that always first, right? Because then your choices are much more broad. If there is no way to submit any of this without decalcification, such as a bone core for metastatic disease, which is all bone with tumor infiltrating between, predominantly ossified tumor like osteosarcoma that is very dense, or tumor diffusely infiltrating bone, and you're not going to be able to pick out any soft component, okay? If there's no way to submit any tumor without decal, then you want to consider, if it's a biopsy, you may want to decalcify entirely in a gentle solution, such as EDTA, after fixation, right, to preserve the nucleic acids. If it is a larger specimen, you may want to decalcify at least one or more sections in a gentle decalcifier like EDTA, again, after fixation. And you can do additional in your harsher, regular HCl. Right? Why? Why am I talking about all these different decalcifiers? Aren't they all the same? Definitely not. So, brief review of our decal options. So there are strong acids like hydrochloric acid, HCl, which is what's used in most labs, or nitric acid. This is fast, throw it in the cassette, couple hours, it's decalcified. But it destroys nucleic acids. They're gone. Can't do any sequencing. There's weaker organic acids like formic acid. It's a little bit slower. It's thought to be somewhat more gentle, but still not great at preservation of those nucleic acids. And lastly, there are chelating agents, EDTA. I'm not even going to try to pronounce that. EDTA. It is the slowest, but it can take hours, mostly days, sometimes even weeks, but it is definitely the most gentle and best at preserving the nucleic acids. So you might ask, well, how do I know if a nucleic acid is good or not? Well, we did a trial. So we can look at DNA quantity. In our lab, we need about 100 nanograms quantity for most of our molecular assays. You can look at DNA quality by sort of fragmentation. And you can look at both DNA quantity and quality. I'm not a molecular pathologist, so I had the help of some of my friends to do these tests. We're going to focus on the DNA quantity in these cases. So we did a pilot study of regular HCl hydrochloric acid versus formic acid, specifically the Formical 2000 commercial brand, versus a gentle, very low percentage, 5% EDTA versus no decal. So you can see the HCl was the worst. Hardly any DNA was left. Formical had a little bit, but remember, we still need 100 nanograms quantity for any of our testing. So both HCl and formic acid are out, but 5% EDTA and no decal, we have quantities over 1,000, right? So this is looking good. Visually, here it is, right? We're looking for 100 nanograms for both EDTA and no decal. We were in the thousands, but for the others, way below. We did a subsequent follow-up study trying to increase our percentage of EDTA, because the lower percentage of EDTA, right, the longer it's going to take to decal, the higher percentage of EDTA might be a little bit quicker. So we tried now increasing it to 10 and increasing it to 18% EDTA. We decalcified just some tissue that we had. We decalcified some tonsil for the hematopoietic cells. We decalcified a solid tumor in EDTA, 10% and 18%, 0, no days, no decal, right? All the way up to 21 days or 3 weeks in either or both of these solutions, right? So you can see we have tonsil in 10%, tonsil in 18%, solid tumor in 10%, solid tumor in 18%, 0 days, 1 day, 3 days, 7 days, 14 days, 21 days. All quantity on this bar graph below, all were at least 100 or more than 100 nanograms quantity after 3 straight weeks in EDTA, right? So this was awesome. The point is, always critically evaluate those specimens that need decalcification, because we found that this gentle decalcifier, EDTA, is super great at preserving nucleic acids. It might take a bit longer, but you at least have an answer, right? So always critically evaluate the need for decal. If it is a biopsy for possible tumor and it all needs to be decaled, remember, please use that EDTA. In our study, up to 18% EDTA for 3 weeks was totally fine. If it is a medium to large specimen and you can grossly see tumor, then of course, if there's anything soft, just submit as much soft as you can without decal. You can submit some following HCl if you have soft. If you have definite soft viable tumor, then you may not even need EDTA, right? Because you've obviated the need for decal in all the tumor. But if you do not have any tumor that cannot be decalcified, right, then you have to use at least some combination of EDTA and HCl. But always, please run this by your pathologist for their advice. We're always happy to work with our prosectors, because sometimes there are questions that we know are coming. At least at the University of Chicago, most of our malignancies end up getting next generation sequencing anyway. So it used to be, oh, this was only by request. Please, please, please make sure the tissue is satisfactory. Today, everything. I would just assume that a specimen is going to be needing molecular testing, at least if you're in a tertiary care institution. But then these patients, even at smaller institutions, get referred to tertiary care institutions, and then the molecular testing is requested. And then if the tumor is all decalcified, you can't do it, right? So the reason is for, personalized medicine. The physicians are trying to find targeted mutations that they can target with very specific chemotherapies. And so this is becoming the wave of the future. So always keep it in mind. Okay. Right. So the next thing we always want to remember is to document decal in your lab information systems. In our case, we dictate in the cassette summary which cassettes were decalcified and in which solution. Our sort of default is HCl. So if we say just decal, we're going to assume HCl, but we have to specify at least which were EDTA decalcified so that we know that these are the ones for possible molecular testing. Dictating this in your gross description confirms that the decalcification charge to the patient is legitimate and confirms again which blocks can be used for molecular. Here's a photographic example of those options. So the 10% EDTA is this mole decal solution, which is what we use in our lab. There's also the higher percentage 18% EDTA, and then just our regular HCl, which I think is used in most labs as well, the SurgiPath. Ooh, bonus. Wow, did I just turn green when my screen turned? I kind of did. What to do when the tissue is too soft, as in the slime monster, right, from the Ghostbusters. So, I love bonuses, right? So in this case, the bonus, what do we do when tissue is too soft, but we need to cut it? So an example I like to use is ENT frozens. So at the University of Chicago, and maybe at your own institution, ENT surgeons are sending mucosal excisions for frozen, for intraoperative evaluation, to determine one of two things: the depth of invasion of squamous cell carcinoma, of which 3 millimeters or more is important for cutoff. Beyond 3 millimeters, they're going to do a neck dissection. So if they can do it day of surgery, great. They don't have to go back. They're also looking for distance of squamous cell carcinomas to the nearest deep and peripheral margins, right? Anywhere between 1 and 5 millimeters is considered an important cutoff for invasive carcinoma, and certainly any positivity at the edges for in situ carcinoma. This will result in immediate margin re-excision from the area that we tell them is positive, right? So both impacting immediate patient care. These specimens, when you get these tongue or mucosal ellipses for frozen, should be oriented, inked, and essentially sectioned freshly in the same manner that you would normally proceed for an oriented mucosal excision, right? You measure the specimen in 3 dimensions, you ink the deep and peripheral margins, your 2 colors parallel to the long axis, you serially section it perpendicularly. Well, sometimes you may think this is slippery, it's hard to cut, I'm not getting a full cross section. So these can be gently submerged in liquid nitrogen to firm up the tissue planes between the mucosa, the muscle, and or the fat. This allows those planes to be serially sectioned into thin and regular slices. I don't require use of this procedure, but a lot of the residents have found it easier to actually cut post a little gentle freezing, especially if they're not used to cutting those softer planes. So here's an example of one of our residents who loved this technique, showing what he does. So we take the liquid nitrogen from the nitrogen tank into the transport, end up pouring it at the table into the styrofoam container, in which then the small specimen is sort of immersed and then removed as soon as it's firmed up a little bit. You can always kind of dunk it back in again if it needs a couple more seconds, but it's a very brief process when these specimens are very small. And then it's firm, and then it can be serially sectioned. So here's a photograph of that exact frozen specimen after it's thawed a little bit, laid out in its serial section, perpendicular to the long axis, where the two tips, right, on either side, here the left and here the right, can be taken a little bit thicker just to facilitate perpendicular sectioning of those tips. If tumor is anticipated to be present in those tip sections, you're also going to want to perpendicularly section those, because the surgeons are asking you if any of their margins are positive, right? Is the deep, which is, here, is the peripheral, which is of course on either side. And then of course, the peripheral also includes each of the tips. So we will evaluate the closest point of invasion to the deep and all peripheral margins, right? So 360 degrees around the specimen, freeze what's relevant. Sort of, I say if the tumor is grossly within 5 to 10 millimeters of a given margin, freeze 1 or 2 of the relevant closest. If no tumor is grossly present, or if it's over a centimeter from the margins, this can be, in some cases, attempted to be called back as a gross only report back to the surgeon, because you're never going to get the tumor interface to the margin if you can't even get it on a slide, right? So then it's just a gross measurement. But if you can get it on a slide, 5 to 10 millimeters, I would recommend you freeze that relevant section. Here's an example of a frozen section from this specimen where we can see the peripheral margin inked sort of blue here. We can see coming around to the deep black. And then of course, this is our pathologist's cut, because it was probably too wide to fit in a chuck, a frozen chuck, right? So for example, we will then be measuring the depth of invasion. Remember, 3 millimeters is key for them to do a neck dissection. And then we will also measure the distance to margin, where 1 millimeter, sometimes up to 5 millimeters, can prompt re-excision of that margin that you tell them is close. All right, so after the frozen, the specimen's essentially already been grossed. It's been completely sectioned. I argue that these should essentially be immediately cassetted and documented, dictated by the frozen person, whether it's the resident or the PA. Again, these perpendicular or end margins should be further sectioned if not already done. I advocate using slice numbers so we can nicely walk through the slices and know exactly where we are. If it's a large specimen and you don't submit every slice, then you can go back and know exactly where you are on the specimen if it's designated numerically. All right, so for this technique, you can, again, use the freeze and liquid nitrogen technique for very soft, challenging specimens, whether it be a mucosal or a skin ellipse, where there is slippage between the tissue planes. Certainly this depends upon your preference between the prosector and the pathologist. I wouldn't recommend this for specimens in which nuclear features are critical, like thyroids, for example. In fact, we don't freeze thyroid really ever or at all, even microscopically. That's a whole nother lecture, which I'm happy to talk about. But nuclei can get some freezing artifact in this. So for squamous cell carcinoma, okay. But for other types of tumors, I would really urge caution and just ask your pathologist if it's okay, perhaps before you proceed with it. So did we accomplish our goals? All right. Did we identify at least 4 methods to approach complex specimens and determine when those methods should be used? So we use freeze for closely admixed soft and hard. We also use freeze for fresh mucosal ellipses. Right? We used shave when the tumor is mostly in the bone. We used score when the tumor is mostly in the soft tissue. And we used the rare fix and decal totally for delicate specimens. We talked about molecular testing and how you should proceed if molecular testing may be desired, as in your harsh decalcifier HCl will destroy nucleic acids, but your gentle chelating agent preserves them. We recommend EDTA. So I'm happy to open the floor for discussion.